Welcome, everyone, to another deep dive. We're focusing this time on something super important for you surgical residents out there, especially those getting ready for those big board exams. You know, the ones like the FRCS plastics.
Yep, those exams.
Today, we're going to really zero in on acute compartment syndrome,
ACS.
ACS, a condition you absolutely have to know inside and out.
Yeah, you got it. A limb-threatening condition. It's not just some theoretical concept you got to memorize. We're talking about real-world, rapid recognition and management that can literally make the difference between saving or losing a limb.
No pressure.
So let's just jump right into it. ACS happens when the pressure inside a closed muscle compartment gets so high, it basically chokes off the blood supply to the muscles and nerves in that area.
Like it's too crowded in there?
Basically, the pressure in the tissues gets higher than the pressure pushing blood in, so you end up with ischemia.
And what happens if you miss this? I mean, it sounds pretty bad.
Yeah, the consequences are, well, they're pretty catastrophic, actually. You can see tissue death, necrosis, permanent loss of function, even kidney failure and death.
Oh, wow.
And this can happen in any compartment, too. We're talking hand, foot, even the buttock or abdomen.
I didn't realize it could be that widespread.
It can, but the anterior compartment of the lower leg, that's the most common spot. Somewhere between 2% and 12% incidence, probably because that's where a lot of injuries happen.
Right. Makes sense.
Another thing to keep in mind, almost a third of limbs with vascular injuries, those can develop ACS.
Really? A third?
Yeah, that's a big chunk. And there's a study by McQueen and his team. You'll definitely want to know this one for your exams. They found that 69% of ACS cases were linked to a fracture, and about half of those involved the tibia.
So fractures are a big red flag.
Absolutely. When we're talking about the leg, the anterior compartment is the most often hit, followed by the deep posterior compartment. Up in the forearm, the deep compartment muscles, those are particularly at risk. That's your flexor pollicis longus and flexor digitorum profundus.
Those are the ones close to the bone.
Yeah, right next to it. And interestingly, we see ACS more in males, likely because they tend to have more traumatic injuries.
Okay, so we've got a good handle on what ACS is and where it usually shows up. But how does it actually develop? What are the mechanisms behind it?
Well, there are basically two main ways this thing gets going. Either you've got too much stuff inside the compartment, increasing the volume, or the compartment itself shrinks, decreasing the volume.
Okay, so two sides of the same coin. What are some examples of things that increase the volume?
The number one culprit is fractures and dislocations. Then you've got ischemia reperfusion injury.
So that's like when you restore blood flow after a vessel's been blocked.
Exactly. And then there are soft tissue injuries, the crush type bleeding into the compartment, even really intense muscle activity. Think exercise, seizures, or tetany.
Oh, wow. I wouldn't have thought of those last few.
And we can't forget envenomation, burns, especially those electrical burns that cause a ton of swelling. Oh, and post-viral rhabdomyolysis, too.
Okay, that is a pretty extensive list. And what about the flip side? The things that decrease compartment volume?
The classic example there is circumferential burns. Those can cause constriction around a limb. Also, anything that compresses the compartment from the outside, like a tight bandage or a cast that's too snug. Even just keeping a limb in the same position for too long, like during a long surgery or if a patient is paralyzed, that can reduce the space inside and lead to problems.
So we've got all this pressure building up inside the compartment. What happens next? How does that lead to actual damage?
It's a chain reaction, basically. This rising pressure within a compartment that can't expand directly reduces blood flow. That means less oxygen reaching the cells. And the body tries to fight back at first, tries to increase the pressure, pushing the blood through. But at some point, as the pressure inside keeps climbing, that compensation just doesn't cut it.
And this all has to do with perfusion pressure, right?
You got it. Tissue perfusion is all about the difference between the pressure pushing blood into the capillaries and the pressure pushing fluid out into the tissues. Think of it like a garden hose. You need enough water pressure to get the water out the end of the hose, right?
Makes sense.
So normal oxygen tension is about 5 to 7 millimeters of mercury. Normal capillary perfusion pressure is around 25 millimeters of mercury, and the pressure in the interstitial fluid is usually 4 to 6. But in ACS, the interstitial pressure goes up, 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 and at some point it just overwhelms the perfusion pressure. No more oxygen getting to those tissues.
And that affects the veins too, right?
Oh yeah, big time. As that pressure inside the compartment goes up, it also pushes on the veins, makes it harder for blood to get out. Once the pressure hits about 30 millimeters of mercury, blood flow essentially stops.
30. That's the magic number.
It's a critical threshold for sure. And now, because there's no oxygen getting in, those cells are forced to switch over to anaerobic metabolism.
Anaerobic meaning without oxygen.
Exactly, but that's a really inefficient way to produce energy. It leads to a buildup of lactic acid and depletes the cell's energy stores.
So the cells are basically suffocating and running out of fuel.
That's a good way to put it, and it gets worse. That lack of energy causes a critical pump in the cell membrane to fail.
The sodium-potassium pump.
That's the one. And when that pump fails, fluid starts rushing into the cells. They swell up, causing even more pressure inside the compartment. It's a vicious cycle.
So it's basically a runaway train at this point.
Pretty much. And as that pressure keeps squeezing, it starts to damage the capillaries that bring in nutrients. You get anoxia, which is basically no oxygen. Then there's lipid peroxidation, inflammation, white blood cells rushing in. The cells start producing something called hypoxanthine.
Hypoxanthine, what's that?
It's a byproduct of this whole oxygen-deprived mess, and it sets the stage for what we call the no reflow phenomenon.
No reflow, what does that mean?
It means that even if you do manage to get blood flowing back into the compartment, the damage is already so severe that the tissues can't use that oxygen anymore. It's irreversible at that point.
So it's not just about restoring blood flow. It's about doing it quickly.
Exactly. Timing is everything here. And to make matters even more complicated, there's something called reperfusion injury.
Wait, so restoring blood flow can actually cause more damage?
It can, at least initially. When that oxygen-rich blood suddenly comes rushing back in, it reacts with all that hypoxanthine that's been building up. This creates superoxide and other nasty free radicals that can damage the cell membranes even further.
It's like pouring gasoline on a fire.
Yeah, kind of. And to top it off, this reperfusion can trigger blood clotting in those tiny capillaries. So you've gone to all the trouble of restoring blood flow, but then new clots form and block it all over again.
So we're talking about a really complex cascade of events all happening very quickly.
That's the challenge with ACS. It can escalate really fast, and that's why recognizing it early is absolutely crucial.
So if we want to catch it early, what should we be looking for? Our sources emphasize that history and physical exam are key, and then confirming the diagnosis with an ICP measurement.
Absolutely.
What are the red flags in the patient's history?
The most important thing is pain. If the patient's pain seems way out of proportion to their injury, that's a big warning sign. Also, if the pain is there even when they're resting and it gets a lot worse when you passively stretch the muscles in the affected compartment, that's another huge clue.
Pain with passive stretch. Got it.
You always want to pay close attention to the mechanism of injury, too. How did this happen? And any other medical problems they have, especially if they're on blood thinners.
Right. Those can make things a lot trickier.
They sure can. And then there's the classic 6 Ps. Pain, pallor, poikilothermia, pressure, paralysis or paresthesias, and pulselessness.
The 6 Ps, every med student's favorite mnemonic.
Right. But here's the thing. That last P, the pulselessness, that's a really late sign. By the time you can't feel a pulse, the damage is already pretty advanced.
So don't wait for all 6 Ps to line up before you get worried.
Exactly. The more Ps you have, the higher the suspicion, but don't wait for all of them.
Are there certain types of injuries or patients we should be extra cautious with?
Absolutely. High velocity injuries, long bone fractures, high energy trauma, those are all high risk. Penetrating injuries, those can damage arteries. And even if you can feel a pulse, don't let that fool you. It could be a venous injury. Crush injuries, patients on anticoagulants even after a minor procedure, and anyone who's been doing really intense physical activity.
Athletes, you mean?
Yep, athletes, anyone pushing their muscles to the limit. And remember, diagnosing ACS in kids can be tough because they might not be able to tell you what's wrong.
That makes sense.
So you really have to rely on your physical exam skills in those cases.
So let's talk about that physical exam. What are the crucial things we're looking for there?
Serial exams are really important. You want to check the patient over and over and compare the injured limb to the healthy one. Again, that pain with passive stretch, that's one of the earliest and most reliable signs.
So if you stretch those muscles and the patient yells, that's not a good sign.
Not good at all. Paresthesias, any tingling or numbness, that means the nerves are starting to get affected. Paralysis, where they can't move the limb, that's a late sign, meaning both the nerves and muscles are in trouble. And like we said before, pulselessness. If you can't feel a pulse, that's a really bad sign.
So basically, we're looking for any signs that the muscles and nerves in that compartment are unhappy.
Exactly. The earlier you catch it, the better.
Okay, so we've got the history and the physical exam. What about lab tests and imaging? What role do those play in the workup?
Lab tests are helpful, but they're not going to give you a definitive diagnosis of ACS. They can support your suspicion, though. You might see things like high potassium, creatinine, CCK, and myoglobin in the blood and urine.
Especially if there's rhabdomyolysis going on.
Exactly. Rhabdomyolysis is when muscle tissue breaks down and those byproducts end up in the bloodstream. If there's been a lot of bleeding, the hemoglobin and hematocrit might be low. And depending on the situation, you might want to check toxicology and coagulation studies. But the real workhorse here is imaging.
Imaging. So what do we order? X-rays, CT scans.
Plain radiographs are essential, especially to rule out fractures. Ultrasound can be helpful to check for blood clots in the veins, deep vein thrombosis, and to assess blood flow, but it doesn't diagnose ACS.
So what does diagnose ACS?
The gold standard is actually measuring the pressure directly inside the compartment.
How do you do that?
There are a few different devices out there, but they all basically involve inserting a needle into the compartment and measuring the pressure with a gauge.
Sounds a little invasive.
It is, but it's the most accurate way to confirm the diagnosis.
So what pressure readings should we be worried about?
Normal pressure inside a compartment is less than 10 millimeters of mercury. If the pressure is 30 or higher, that's when we usually recommend surgery to relieve the pressure. Some folks also look at the difference between the compartment pressure and the diastolic blood pressure.
Diastolic, that's the bottom number, right?
Yep. So if that difference, the delta pressure, is 30 to 45, that's another sign that surgery might be needed.
Okay, so those are the numbers to remember. Are there any other fancy ways to measure pressure?
There are a couple of newer techniques being investigated, like near-infrared spectroscopy, NIRS, and laser Doppler flowmetry.
Sounds high-tech.
They are, but the evidence for them isn't quite there yet.
So stick with the needle for now.
For now, yeah. And one more thing. If you're measuring compartment pressures, you want to make sure you do it close to the fracture site. Aim for within 5 centimeters.
5 centimeters, got it. So let's say we've diagnosed ACS. The pressure's way too high. What's the next step? What's the treatment?
The only definitive treatment is surgery to open up those tight compartments and relieve the pressure.
Fasciotomy.
Exactly, fasciotomy. But if this is a trauma patient, make sure you follow the ATLS protocols first.
ATLS, Advanced Trauma Life Support.
Yep, always got to stabilize the patient first. But once they're stable, fasciotomy is the priority. And remember, time is of the essence here.
How much time do we have?
Well, irreversible damage can start as early as 3 hours after the injury. And studies have shown that muscle viability really starts to plummet after 6 hours. So that's kind of the golden window.
6 hours? That's not a lot of time.
It's not. And that's why early recognition and treatment are so critical. The goal of a fasciotomy is to open up those compartments as quickly and completely as possible while trying not to disturb any fracture fragments if there are any.
Right. Don't want to make things worse.
Exactly. And in some cases, like if a limb has been without blood flow for a long time and then we restore it, we might consider doing a prophylactic fasciotomy.
Prophylactic meaning preventative.
Exactly. To head off any potential compartment syndrome before it even develops.
That makes sense. What about those cases with snake bites, the envenomations? How do those factor in?
With envenomation, the muscle damage is probably a direct effect of the venom itself. But if the compartment pressures are high, we'll still do a fasciotomy. And of course, you also want to give antivenom and antibiotics.
Right, to neutralize the venom and prevent infection.
Exactly. And by the way, make sure you take a look at the figures in the source material. They show the different fasciotomy incisions for different parts of the body.
Good point. Those diagrams are super helpful for visualizing the procedure.
Yeah, definitely.
So the patients had their fasciotomy. What happens after surgery? What does the post-op care look like?
Mostly supportive care, pain control, keeping the wounds clean. Dressings are usually wet to dry.
Wet to dry. That's the one where you put a damp gauze on the wound and let it dry, right?
Yeah. Yep. And we rarely close the wound right away. Usually it's a delayed closure or even a skin graft later on. There are also some newer techniques like vacuum-assisted closure that can help with healing. If the patient had rhabdomyolysis, we'll give them lots of IV fluids to keep them peeing well.
How much pee are we talking about?
We aim for 1 to 2 milliliters per kilogram per hour.
Okay, that's a lot of pee.
It is. And there's some thought that mannitol might be helpful in these cases too, but we need more research on that.
Mannitol, that's a diuretic, right?
Yep, it helps flush things out.
So we've talked about how important it is to catch and treat ACS early. But what happens if we miss it? Or if treatment is delayed? What are the potential complications?
One of the most devastating complications is Volkmann's contracture. This usually happens in the upper extremity, the forearm. The muscles basically die and get replaced by scar tissue, which pulls the hand into a claw-like position.
That sounds incredibly painful and debilitating.
It is. It can severely limit hand function.
And that's not the only bad thing that can happen, is it?
Unfortunately not. You can also have limb loss, permanent nerve damage, kidney failure, and even death.
Wow.
And even if you don't have those really severe complications, you can still end up with significant scarring, muscle weakness, problems with tendons, and chronic pain.
So the take-home message is don't mess around with ACS. It's serious business.
Absolutely. Early diagnosis and treatment are essential.
Speaking of which, let's do a quick recap of those key points for your board exams.
Sounds good. So ACS can be caused by either decreased compartment volume or increased contents. Disproportionate pain and pain with passive stretch are early signs. Pulselessness is a very late sign.
Late and ominous.
Exactly. If the pressure inside the compartment is 30 millimeters of mercury or higher, you need to decompress it.
Via fasciotomy.
Right. The best outcomes happen when you intervene within 6 hours of the injury. Be on the lookout for rhabdomyolysis, and if it's there, treat it aggressively. And remember, if you miss ACS, you could end up with a Volkmann's contracture.
Excellent review. And to all our listeners out there, remember, rapid recognition and management of ACS are absolutely critical. Don't delay.
Be vigilant. Have a low threshold for suspicion.
Do you see those early signs? Don't hesitate to act. And to really solidify your knowledge, I encourage you to dive deeper into the techniques for measuring compartment pressure and familiarize yourself with the different surgical approaches to fasciotomy.
Absolutely.
Those are life-saving skills.
And one final thought. Given that we're dealing with such a tight time frame, what are the absolute deal breakers? The red lines that should trigger immediate action in a suspected case of acute compartment syndrome? Think about it.
Excellent question. Something to really ponder.
Because in this game, every minute counts.
Absolutely. All right, that's it for our deep dive today. Thanks for joining us, and stay tuned for more.
See you next time.